I think we've already gone through this, so I won't spend much time. We've all gone through the for first generation, the second generation, and the third generation, and the fourth generation formulas, and then the newer formulas which are coming up, and even newer ones which are, which even Doug Cox spoke about. And this is how it looks. And I've been so excited to be involved with the Hill RBF, as it grew from the Excel sheet to the online calculator to the integration into the Lenstar. And then I've been working with the Lenstar for many years. And only like 2 weeks back, my Lenstar got upgraded to the Hill RBF 3 and the posterior corneal curvature integration. And it's so exciting. I'm enjoying playing with the machine now and with for all our patients. So this is how it looks. I mean, for the normal eyes and all kinds of eyes. And you can see here that at the bottom of the stack is the Barrett's calculator and the Hill RBF, which can go really far for the short eyes and the long eyes. I've really enjoyed the Hill RBF for the long eyes because it seems to work best for me, better than any of the other formulas for the long eyes, and now also for the short eyes because it's really enjoyable. And frankly, let's go on. So Olsen formulas, this is for the sake of completion of what we have, other than what works best right now and what's coming up probably. So we all understand that the Olsen is based on the ray tracing principle with a C constant, and it's a fraction of the lens thickness by which the center of the eye will locate itself post-operatively. And this concept was published in the JCRS, and it is thought to be the new ray tracing principle. And I won't go into the details because for quite some time, and I don't want to go into a theory of the formulas, but I think we've spoken a little bit about the Olsen before. And that brings us to the artificial intelligence and the Hill RBF calculator, which I've personally been working with for many years. And initial, as Warren said, I was involved with the initial part of the study, and then we've seen it grow. And I'm seeing the Hill RBF 3, and we'll see the advantages of that. So as we all understand, we've just had a talk. I will not talk more about it. What I love about it is the out of bounds feature, and that tells you sometimes when you have an eye which may have peculiar measurements, because it may look normal, it may have a normal excellent to initial exam, and it might look like it looks like a normal eye, and other formulas are not going to predict that this is going to be possibly an eye with a refractive surprise, but the Hale RBF will immediately label it as out of bounds. Of course, now that Warren has a huge database, so the number of out of bounds are going to be really small. But till we didn't have this bigger database in the Hill RBF2, we would occasionally have an out of bounds eye, and that would immediately make me, kind of watch out. Is this eye potentially, why is it showing out of bounds? And you might sometimes see that the AC depth is suddenly much smaller for an eye which is much longer, or maybe the keratometry is a little off for an eye which otherwise looks totally normal, and that would suddenly put these eyes at risk of refractive surprise. And that has saved us many a times for situations where we looked and relooked and then went more carefully and got a good result. So the Barrett suite is something which also has become very popular, especially with the Almaster 700 integrating the Barrett suite into the system. So the posterior surface of the cornea gets included in the Barrett suite, and it includes 3 of the formulas, typically the Barrett's Universal 2, which is all for the non-toric IOLs, the Barrett's toric, and also the Barrett's True K for all the non-torics after refractive surgery. And the Barrett's Universal 2, of course, is Burgess-based formula. And we all understand that it's based on the model eye in which the AC depth is related to the axial length and to the keratometry. And it takes into account the A constant and lens factor, which helps determine these formulas. And it frankly works really well for all kinds of eyes. And this has become a very integral part of the biometries of all optical biometers. And a huge number of people in India, at least, are using the Barrett's Universal 2, and they depend on this for the reason that it is integrated into their biometers to a large extent, and of course is available online as well. So again, this has been accepted as one of the most accurate IOL formulas today. And as we understand that, it has come a long way today. And let's go on to what all it requires. What is essentially required for the Barrett's is the axial length and the keratometry and the lens factor. And of course, if you would also put in the AC depth, the white to white, and the lens thickness and the design factor, it would obviously increase the accuracy. So the lens factor is calculated out of the SRKT, whereas the design factor is IOL specific and definitely influences the IOL calculation. And as we understand that the precision can be much more if you have the design factor of the specific IOL that you're planning to use. Again, if you also have these 3 parameters. It will increase the accuracy, just as the Hill RBF3 has taken into account some of the new things with the corneal thickness and the white to white, and those variables that Warren spoke about. That initially when we started out, we just wanted to choose those 4 variables, which would give us very few out of bounds. And now that we have a huge database of patients, you can add these for more precision and lesser number of out of bounds eyes. Same way for the Barrett's, I think it works out that it becomes more precise when you have more the lens thickness and the AC depth put in for predicting the lens, the better IOL prediction. Now, the Barrett's toric calculator, I think it was something which really revolutionized our toric implantations, and today I think almost all company formulas have started using some form of derivation from the Barrett's toric calculator for their own calculators, integrating the nomogram for the posterior corneal astigmatism, and which is not really measured, but it's derived from the anterior keratometry. It uses basically a nomogram to predict the posterior corneal measurements and uses that for the calculations, and it has shown excellent results. And today I have used the Abulafia Koch calculator, which also comes on the Lenstar, and I've seen that the Barrett's toric and the Abulafia Koch, they both compare pretty well, and these have really changed our way of understanding. And today we do an toric calculation for all patients, and even those with the smallest of astigmatism. And it's surprising to see that occasionally there'll be patients with just 0.5 astigmatism where we'll end up implanting a toric lens, and there'll be others because of the difference between the with the rule and against the rule astigmatisms. So I think again, most people are using the Barrett's toric calculator today. And then, of course, coming on to post-refractive surgery, I think the True K formula is something which is very, very useful today. And amongst the gamut of few formulas which is there on the ASCR calculator, as well as onto our machines, where the Shamas and the True K, we really have started using more and more of the Barrett's True K post-laser vision correction formula. I will not go into the details for the sake of brevity, and it does perform well. So another thing which gets integrated with the IOLMaster 700, and I'm not a user and I have no financial interest, is the total corneal power. So it gives you the TK. Now, there have been mixed opinions about the value of the TK, as Dr. Douglas Koch as well pointed out about its utility for healthy normal eyes. But definitely when you come to post-refractive surgery eyes here, the measurement of the posterior corneal curvature will make a difference. And so it basically gives you additional data, and instead it replaces the posterior model with actual posterior measurements, and that results in 2 new formulas, which is the Barrett's TK Universal 2 and the Barrett's TK for the toric. And I think it has a place at least for the toric calculations for sure, and one should definitely look at it, but whether to use it or not is something that you have to take a judgment yourself. And coming on to a couple of the other formulas which have also been pretty useful of late, and they're coming up really well, is the Super Ladders formula, which actually incorporates many of the existing formulas into a single equation, and then it picks which formula might work best for you. So it also incorporates data, and it's in real time that it's growing with more and more numbers, and it kind of tries to visualize the formulas in 3 dimensions. And it's a novel approach because it kind of uses different formulas and then try to see and improve upon them to give a kind of a personalized kind of a measurement for you, a personalized constant. In that way you can derive, or from the benefit of other users around the world, where you can kind of grow onto your own formula and come out with a better result. The Kane formula sounds exciting too, and it kind of was in few studies has been shown to be very, very accurate. And it was came up in September 2017, and with almost 30,000 highly accurate cases. They have a formula for the toric formula as well, and they have one for keratoconus as well, which is derived from the regular Kane formula. And it has the fields of the A constant, it has the gender, the axial length, corneal power. So as we were talking about gender, so this one includes gender, and the anterior chamber depth, and you can add the lens thickness and the central corneal thickness, which will improve the prediction, but it's not compulsory. So this again has been a formula in evolution, and supposed to be, many people find that the Kane formula is supposed to be very good. There have been studies which have shown that big advantages of using the Kane formula over the others. This was one of the studies which I could find. It concluded that using 3 variables, the axial length, the keratometry, and the AC depth, the Kane formula was more accurate predictor of actual post-op refraction than the other formulae, where they compared it maybe even to the Hill RBF2, the Holiday 2, the Olsen, the Barrett's Universal 2, the Hagel's Holiday 1, Hoffer Q, and the SRKT. Now, of course, different studies might come up with different results, but this was one of the studies which showed up. And then we have my friend FAM's formula, who is contributed to this, the Evo formula, which again is thought to be one of the contemporary very good formulas, and it is known as the emmetropia verifying optical formula. It's basically based on the theory of emmetropization and generates an emmetropia factor for each eye. And we won't go into the details, but this is another formula which is available online, and this is the fields which are required for this formula. So this can definitely be another formula which you can consider. We have our friend from India and who's worked with Dr. Vavikar, who was supposed to be on the panel. There is Saurabh Sani, who has developed a toric calculator along with Dr. Vavikar, and he's been working on artificial intelligence. And as Dr. Warren said, that he's excited about somebody in India who might be working on, the concepts that Warren has kind of brought forward. And he has been working on two different artificial intelligence systems. One is his formula, which he currently says that he's still, it's an evolution. And he's also working on dynamic IOL optimization, where it kind of maintains your. It's like for developing a personalized A constant, and it constantly gets updated with your own results using an Excel sheet, and can grow your, give you more kind of personalization. So with that, I think I'll come towards the end of my presentation, trying to give you a hint into what new formulas are doing. But I found this one study which compared the accuracy of 11 intraocular lens power calculation formulas. This is published somewhere in October 2020, and where they have compiled data from 481 eyes and compared many of the formulas, so almost 11 of them. And they tried to say that, as far as the results goes, they found Barrett's Universal 2 and the Haigis. Now, obviously, this did not include the Hill RBF 3, which will probably change things a little bit. But these two, the Universal 2 and Haigis, yielded any length range, as well as in the long and the normal. And in the short eyes, they found that the Haigis and the Evo formulas seem to perform really well. So this is how it went. And I think with that, I would like to lead on to the discussion, and I'll stop sharing my screen now. So
Thanks very much, Gaurav, for a lovely, quick presentation, a bird's eye view of what's happening around. Brilliant coverage in a very short span of time. Welcome, Vavi, for being there. And Dr. Hill, now that we have this lovely formula, would you have, you can collect the data across the world. Would it matter if you have the Caucasian eye, the Asian eye, or the European eye? And would that strangulate your data, or would you be doing separately for people?
Well, most of our patients are of European ancestry. We have some pretty large databases from India, down in from the group, the Arabic group in Tamil Nadu. But the majority of patients are European. For the ethnic Chinese group, we have databases from Hangzhou, from Shanghai, from Hong Kong, Taipei, and Singapore. And so those are exclusively Chinese eyes. And so we'll be concentrating on that for the Chinese artificial intelligence algorithm.
So those eyes would be different, behaving differently than the other eyes, possibly.
Well, what we found is that if you talk to somebody, say in Hong Kong, who does multifocal lenses, they have a different idea as to which formulas work better, because as we mentioned before, the enter segments of many Chinese eyes tend to be a little smaller and a little bit more crowded. And I think it has an influence on lens power calculation. And so I've looked at many Chinese databases, and with formulas like Haggis, they do very poorly. They don't do well at all because the lens constants were optimized against European databases. They like SRK2 for some reason. That seems to perform well. It's a favorite amongst the Chinese ophthalmologists. And maybe it's just because they're using something that's older and they're familiar with it, or maybe it's because they like it. But the universal feedback that we get is that our formulas that come from European databases are not really all that good for the Chinese eye. What's interesting is that not all Chinese eyes are myopic. The classic eye that we think about has a little bit smaller anterior segment and a larger vitreous cavity with a population mean value of myopia. But a number of databases that I've looked at from different portions of China, there are a fair number of hyperopic eyes as well, which is interesting. So there's really a wide range. At the moment, we're just sticking to mainland China because I think there may be some variations amongst Japanese and Koreans or Cambodians, Vietnamese, Laotians. we're going to use that as our prototype and then go further into it as time goes on. It's been a little difficult getting really high quality databases from places other than Singapore, Taipei, and Shanghai. So it's kind of slow going right now.
One question which I would like to ask is, for post-refractive surgery, how's HIL RBF version 3 placed?
Well, it turns out we can't use that at all, because for artificial intelligence to work, we have to have good metrics. And as Doug so eloquently pointed out, we really can't measure these corneas. And it has to do with the Gould-Strand ratio. Many of these eyes have a widely variable power distribution across the anterior segment, across the anterior cornea rather. And so the Gould-Strand ratio may be different in different ways in different places. So until we can accurately measure the cornea, I think artificial intelligence isn't really going to play a good role, because so many of these eyes, whether they've had LASIK, ALK, PRK, radial keratotomy, each eye is unique and individual in their own way. So we're going to need better metrics before artificial intelligence can be used. At the moment, I think the Barrett True K method for radial keratotomy, for myopic and hyperopic LASIK is probably giving us the best results. And our results are in the mid-70s, just like Dr. Koch showed.
I would just sort of add to that even if we come up with great measurements of corneal power in these post-LASIK eyes, because there's variability of power, we don't yet understand how to translate all that variable power into what the patient will select for the IOL or select for the refraction. So there's a whole nother step that needs to be done once we get great measurements front and back, and then trying to interpret it. So we have a ways to go in this setting.
And Doug, I think what you're saying is these are multifocal corneas. And you know, what we think it might be the right power, the patient's using something different, like keratoconus. They don't look through the cone, they always look through an area kind of adjacent to it. And so what the patient chooses and what we choose, there may be a disconnect. So I agree with you completely on that.
Can I chip in with a question here? Sorry, Dr. Ray, please go ahead.
Please go ahead. Please go ahead.
So this led me to think that there was a situation where I sometimes get stuck is when we have a refractive surprise and I want to go back and post-operatively, then we have the benefit of better measurements because you have a pseudophakic eye, and then if you have an occasional refractive surprise and you do a post-operative lens stuff, for example, and I want to look back where you went wrong, and then what do you recommend, Dr. Koch and Dr. Hill, because we can't use the Hill RBF, it can't work on pseudophakic eyes, right? And then we are stuck with the Barrett still work and the SRKT might still work. So what do you recommend that if we have a refractive surprise and we want to go back and we now have more pure data because we have an eye with a better optical system and better measurement of all the parameters, what do you suggest?
Well, I'll go first with this. Basically, a pseudophakic eye is now, we look at it as an existing optical system. So you would need to add power to or subtract power from an existing optical system. And that is actually a very accurate exercise, but we don't base it on the axial length. You would use either the Barrett RX formula or Jack Holliday's refractive versions formula. It would mostly be based on the effective lens position, a careful manifest refraction, and to a small degree decays. And that's probably one of our most accurate methods. So I would advise against remeasuring the eye and using a theoretical formula to come up with a new IOL power. Doug, do you feel the same way?
Completely agree. And this is one situation where absolutely I do the refraction in those eyes because the refraction is the driving force for the entire calculation. Once you know they're off by 0.75 diopters, you have to change the IOL, probably by a diopter, etc. So not something to delegate to a beginning technician.
Especially
can I make a comment?
Yeah, please
I
go
think
ahead,
these pseudophakic eyes, I've used Aura as a major tool in these cases, and I found Aura really helps in these cases and gives you a good calculation, especially in a patient with a surprise.
No, especially when you're planning to do the second eye of this patient where you had a refractive surprise and you don't want to go wrong with the second one. That's where it really pinches you and you're kind of stuck with a situation where how to plan the second eye, and that's why this question.
Well, there's another way to plan the second eye. A lot of people will take, say, perhaps 50% of the error and apply that to the second eye. But let's say the two eyes are symmetrical, and we see this mostly with axial hyperopes. What's happened is that the formula has probably misestimated the effective lens position. That's one of the most common issues. So what you can do is you can adjust the lens constant for the first eye until you can duplicate the refractive outcome, the refractive surprise. And then take that adjusted, customized lens constant and use that for the calculation of the second eye. And what we're doing here is we're giving the formula the opportunity to come up with the right lens power based on an effective lens position that more accurately matches the anatomy of the eye rather than the basic assumptions of the formula. And for the high hyperope, this works very, very nicely.
Thanks, Gordon. I think that makes sense.
Yeah. One question. I'd like to reiterate what Dr. Ramamurthy had already talked. The eighth constant, the eighth parameter you have included is the gender. So I would like you to inform each one of us, how different are the formulas, how different are the results when you take off the gender part of your, the version 3 of your formula?
It's a very small amount. It's about 1/8 of a diopter. But when you're looking at very large databases, you add whatever you need to make the outcomes better. So is it a significant factor for lens power calculations? The answer is no. Does it add something additional? The answer is yes. And is it a hard parameter to gather? No. You just look at the patient. So since it does add something of value, small amount of course, it's easy to get. Why not use it? But as I mentioned, it wasn't until we got into tens of thousands of patients that we could actually see that this actually did matter.
Yeah, I fully agree because trifles make perfection, and perfection is no trifle. So small things are going to make it from 90 to 200, as you said. So these are
as I mentioned before, once you start approaching 90% for a half diopter outcome, I can tell you that all improvements are painfully incremental. In order to get a 2% improvement over version 2, it took 2 years and of like 10 to 30 hours a week for 2 individuals. So this, I think, as Doug alluded to, we're sort of limited by our measurement technology. And there's kind of a biologic floor and a calculation ceiling for how far we can go. And until I think we have better measurement technology, we're going to be bouncing around with the same measurements, the same outcomes. And this is one reason why you might see 5 studies and see 5 different results. It's the measurements. It's not as much the calculation methods as it is the measurements. And we need to get the Ks much better. I mean, like I said, if I had a magic wand, that's what I would want.
The corneal measurement, you're talking about the cornea measurements of the K readings, right?
Right. The keratometry has a tremendous amount of mathematical noise. And if I mention something again, in our practice, we optimize the ocular surface for 2 weeks prior to biometry. We have the patient do warm compresses that helps express the contents of the meibomian glands and stabilizes the ocular surface. We do lid scrubs, perhaps to open up the orifices of the meibomian glands. And then also we do high quality tears frequently throughout the day. And I can tell you that the consistency of keratometry is remarkably better on a topographic axial power map. Those multiple little flat and steep islands that you see, they all disappear. The aberration profile looks better. It really looks good. And let's say somebody has meibomian gland dysfunction that's significant. We might even do a lipoflow treatment on them to encourage the meibomian glands. And it's a significant factor in making these eyes better for the keratometry.
Himanshu, can I ask you a question?
Dr. Ramurthy, you're muted. You were speaking.
Dr. Bhavikar is here. We can,
Can I? Oh, Bhavika, you want? Please go ahead. Dr. Hill, I just want a clarification regarding your concept of out of bound. I think it's a great concept. But with your Hill RBF3 iteration, I think most eyes that we come across in our clinical practice will be within the boundaries. But in case there is a case which is out of bounds, and for most formulae, it's again going to be out of bounds because these extreme eyes are what are challenging. And is my understanding right when I assume that out of bound just means that the 90% chance of landing within my 0.5 diopters is not there. And even in these situations, for the want of anything better, you can go ahead and use your formula.
Yes. So again, it's just for predictive value, but there are a couple of interesting quirks to this calculation method. All calculations methods have little personality differences. And I think, Doug, you were the first one that pointed out to us that even for the axial hyperope, when the patient showed up as an out of bounds calculation, the accuracy was still there. And we're still finding that also. It's an opportunity to have a discussion with the patient, to let them know prior to surgery that there may be a problem. If you tell them before surgery, it's not your fault. If they find out afterwards, you own it, so to speak. So it has a couple of values that way. You get to talk to the patient, and also you might use a different calculation method. So we would go straight to Barrett, and quite often Barrett gives a result that's very similar to RBF3. And then if there was a divergence, we might look to our next trusted formula. But immediately it's a heads up that this is not something normal.
Dr. Cook would like to leave, but before he leaves, I just want a few quick answers from both of you. The regular eye, which formula would you go? For a hypermetropic eye, which formula would you go? For a myopic eye, which formula would you go? Quick answer, quick understanding on that. Because the take-home message for most people who are watching, this is the question.
Still RBF3 and Barrett for all, but in the hyperope, I tend to like the Holiday 2 a little bit better than the Barrett. So for them, the high hyperope, I would go Holiday 2 and RBF3.
And I would echo Doug's observation. So that would be what I would do as well.
And accuracy of measurement, we all agree that it's axial biometry that is there. That's the way to go. And keratometry would be from the IOL calculation that we have for that. Is that right? Is that what that's the main concern that we have?
And you have to look at the spots to see that they're accurate, and you have to check the standard deviations and make sure that, because even the biometers can make big errors if this corneal surface is not good or if the patient didn't blink appropriately.
Right, and I might say that a measurement's only as good as our ability to know what it means. So as Doug points out, following validation criteria is really important. And tell your staff to get out of the habit of just pushing buttons, but think about what it is that they're measuring, and if something's wrong or it doesn't look right, they delete and repeat. And that's the first step towards better measurements.
Putting artificial tears before doing any measurement, it's not supposed to be done. I mean, you said something very interesting. For 15 days you gave them and you cleared out the whole thing. The scenario changed because of that, but your consistency of answers became better with that.
Right, just putting in artificial tears moments before keratometry, I don't think it's going to really be the answer. You need to stabilize the ocular surface. Adi Abulafia in Jerusalem did a wonderful little exercise where he took normal volunteers, did keratometry, and then 1 or 2 days later repeated the keratometry, and it was different. And optimizing the ocular surface helps to remove that variation.
On the same note, if I was to ask a very stupid question, you do refractive calculation for a person, including you, this morning, this evening, and maybe tomorrow and day after. It's bound to be a quarter number, half number here or there. The same two individuals without any subjective changes. Would that be the real dynamics that we're looking at?
Well, here in the desert where I live, I think the ocular surface plays a role. Go ahead, Dan.
Yeah, great. You said it, Warren. That's right. Cornea, 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 cornea. Get your corneas right. Do exactly what Warren said. We do the same thing. We're not as aggressive with warm compresses, but our patients use artificial tears 4 times a day for the week before they come in, or we ask them to. And it's the cornea. That's our message. The cornea and the new formulas.
There you go.
So cornea is ELP and the new formula to concentrate.
Right.
I had a quick question, Himanshu, if you'll allow me, because we have 2 of the masters of biometry. I have had a couple of patients recently who are post RK followed by myopic LASIK as well. and they've been so flat that none of the devices are ready to measure the cornea. And it's been like the pentacam shows up something with the EKR 65 showing up like 24, 25, and some of the devices showing like 28. And it's been crazy because what to trust and what not. So what would you suggest for measuring the cornea for eyes which are so flat that most devices won't measure them, and how would you probably approach them?
Well, I'll make one comment before we go on here, that here in the state of Arizona, we're like one of the radial keratotomy capitals of the world. And the LASIK that they had afterwards was most likely hyperopic LASIK rather than myopic LASIK. And there really is no good answer. I mean, you're way outside the algorithms of all the calculation methods, which usually use some sort of regression-derived method to come up with a correction for the cornea. The only good news is hyperopic LASIK and radial keratotomy change the Gould-Strand ratio in the same way. It's a little paradoxical that one is an incisional myopic procedure, the other is ablative hyperopic, but they both increase the Gould-Strand ratio. So you can ignore the LASIK and go with the majority change, which was due to the radial keratotomy.
Yeah, I completely agree. And those patients, informed consents, everything. I tell that patient you've got probably a 1 to 5 and 1 in 10 chance of needing an IOL exchange. It's just going to be that inaccurate, and prepare them for a second procedure. And if you, by some reason, get it right, you're a hero. And otherwise, you've just met that very low expectation.
Dr. Bhavika,
I need to depart, everyone. I have another obligation. Thank you so much. I enjoyed the conversation and the other talks very much. I wish you all a good evening.
Thank you so much for getting your valuable time before your outpatient department starts, Dr. Koch, and very, very sweet of you to spend this morning with us and give us some valuable information today. Thanks once again, and we ever so grateful to you being always there with a smiling face. We only missed your bow tie, this morning.
Yeah, no. Thanks.
Thank you. Have a wonderful day and a great weekend.
Dr. Bhavika, in this situation which Dr. Gaurav was asking, would you like to add something?
What I would do, perhaps, I don't know, it's open to discussion, that I would I will leave the patient aphakic after 3 or 4 days. When the corneal wound edema settles, I would do aphakic refraction and calculate the IOL power by Vergen's formula and implant that IOL after 8 days.
And if we're talking about a situation after radial keratotomy, remember that these patients are initially hyperopic. And so you need to wait 6 to 8 weeks before you make a decision regarding the exchange. And we use what we call the rule of twos. And that's 2 stable refractions on 2 consecutive visits, at least 2 months after surgery, because these corneas do take a while to stabilize after radial keratotomy, if that's what you're referring to.
Yes, sir. And anyway, doing IOL exchange after 6 to 8 weeks is rather tough. So leaving the patient aphakic, waiting for the corneal edema to settle, and then doing aphakic refraction, and by Vergen's formula calculating the IOL power and implanting the IOL, that will be a bit easier.
No, that's an excellent way to do it. And what I might also recommend is that if you have the luxury of doing the exchange calculation in a stable pseudophakic eye, following radial keratotomy, I would not target plano. I would target -0.5 to -0.75 because of hyperopic drift. The old joke is that radial keratotomy is the gift that keeps on giving. And many of these people will continue to drift towards consecutive hyperopia over time. So you want to keep them a little bit minus with that in mind. That way they'll always be changing towards something better than away from what it is they want.
Excellent. I had one question for you. What about artificial intelligence for toric calculations?
Well, it turns out that we do have that. I think Dr. Luthra had mentioned about the Abulafia-Koch algorithm for toric IOLs, and that's actually combined with the Hill RBF3 method. So if you're using a Lenstar and you use Abulafia-Koch, the spherical component of that is calculated by artificial intelligence, and then the toricity component is calculated by the algorithm developed by Doug Koch and Adi Abulafia, and it's very accurate. It does a very nice job, as Dr. Luthra had mentioned.
Thank you.
In fact, Warren, I wanted to tell you that we did a study recently with out of bounds eyes and trying to see whether those eyes ended up getting a refractive surprise if we still continue to use the Barrett's calculator for Barrett's Universal 2. And you'll be surprised that we found that while Hill RBF would label them as out of bounds, and we went with the implantation, we found that we still had the Hill RBF perform
Better than
predictor, even recommended not to use it, than what the Barrett's was saying. And we're publishing that. It's in publication now, where we've done a comparison of about 100 eyes of out of bounds eyes from the Hill RBF2. And let's see, I'll try to study them on the machine and see if that makes a difference.
Yeah, and I think what you'll find is that if you run the same eyes through RBF3, you'll find that they won't be out of bounds indications at all. For an eye, unless it's very, very unusual, it's highly unlikely to get an out of bounds calculation now. So that's the main advantage of this updated method. And as I mentioned, we spent between 10 and 30 hours a week for 2 years developing this, and I think it represents a real major advantage. We're already working on RBF4, by the way. We have some other ideas as to how we can make it better. But it's become almost a full-time job dealing with this. And I also might mention, people like Dr. Luthra and say the people at Aravid down in Tamil Nadu, they're all volunteers. I mean, everything Dr. Luthra has done, he's done out of the goodness of his heart, and including all the other volunteers around the world. And this is a true worldwide collaborative effort with everybody just working for the benefit of ophthalmology. And it's really nice to see people working together like this with nothing in return except better results. And I think we all benefit from the kindness and generosity of people like Dr. Luthra.
Thanks, Warren. Thanks for those kind words. Sir, since we are in a big forum today, and I have I'm sorry if I'm, pestering everybody too much, but the thing that we just spoke about half an hour back about the final outcomes, the refraction, a correct refraction being the limiting factor, we found the same problem that when we look at big databases, for example, if we look at like 500 eyes or say 1,000 eyes, and we're trying to make sense out of them, we realize that we have maybe 4 different people doing those refractions. We have never been able to find one person or one single person doing the refraction. So when we do big studies, Warren, how do we find that, how do we trust that data? Because, it's not possible that when you have a few hundred eyes, that all the refractions would have been done by the same person and they will be as accurate. So how do you kind of take away the bias? And what's the best way? Is there an objective way of doing the measurements post-operatively to see outcomes and analysis, which is the best objective way if there is one?
Well, and imagine if you have 35,000 cases that you're looking at, and you're going to be basing an artificial intelligence algorithm on refractions that some of them may be by autorefractors or poorly trained technicians, some by the doctors. Not everybody's going to do a careful endpoint refraction like with the red-green duochrome balance. So what we've done is we've developed a method for statistical filtration where we look for improbable outcomes or eyes with very similar axial lengths, Ks, anterior chamber depths, but widely variable refractions. And we figured out a way to identify outliers and improbable outcomes and exclude those from the database. And that took a lot of time. Again, it took a full-time PhD mathematician to come up with engineering-based statistical methods to do these filtrations. For an individual surgeon working in a clinic, you just have to have standards for refractions. We use a duochrome endpoint, or the most simple thing that you can tell your technicians is they start out hyperopic, and if they know what they think the spherical equivalent should be, it's blurry, one click, blurry but better, sharper and darker, then about the same or perhaps not quite as good. And that's probably as accurate as you're going to get it. But I agree that refraction is really one of the limiting steps in this whole process.
So I think that when you're talking about multiple centers and so many thousands of eyes, does the platform that you use to feed in all this data also matters? So something like Veracity, which uses, which could integrate all this information, because quality of the data that you deal with is extremely important. This AI-based formula, would it make a difference?
Well, actually, I was the original technical director of Veracity, so I'm very familiar with that. The problem with Veracity is that it may just look at the most recent refraction. So there's no good filter in Veracity. What we've been doing is we've been having physicians do manual entries into Excel spreadsheets, and that's given us the most reliable data collection. And then we look at the data very carefully and do statistical filtration to look for improbable outcomes, obvious outliers, IOL power interfraction length. We've seen pretty much every type of variation you can imagine. And again, a measurement's only as good as our ability to know what it means. And when we collect data from multiple sources, we're always going to have these questions. So if you can identify outliers, then that's a place to start, and then you can refine that process using sophisticated mathematical methods.
I think we should. I think we have to thank Warren for taking out time and being here, because it has helped all the viewers to solve their queries. The bar has to be raised, and when we are raising the bar, it's not going to be very simple, because from 92 to 100, it's going to take a lot of time. But for each one of us around, whenever we have a surprise should mean not one or more. We have to have a mindset wherein the surprise should be more than plus 0.5 to minus 0.5. If it is more than that, we have to introspect. And when we introspect, we have to go all out to find a solution to this. And for this, I think it has to be an effort wherein your staff members have to be involved. The cornea has not to be ignored by any means by each, as Warren has fully and Koch has said that it has not to be ignored. The cornea, the meibomian gland dysfunction has to be taken into consideration before we really go ahead with it. We have to, thank J&J also for that, because whenever we have, whenever we ask them at any point of time, they've always come up. And I would like to thank Jaspinder for that, and Dr. Himanshu Mehta for coming up with a brilliant idea for organizing such webinars, which would go a long way across the world to elevate and to help us to achieve what we really want to achieve. I would be falling short if I would not be thanking Dr. Bhavikar for taking out time, and Dr. Titial for being there right across, Dr. Ramamurthy for being there, and thank you again, Dr. Himanshu. Would you like to wind up by saying anything else?
Thank you so much, Rohit. Thank you very much. First, I would like to thank Rohit. He's been kind enough to thank everyone, but he's been the backbone for every organization part. He's taken a strong lead support. He's been there, totally there for everything, getting J&J, getting all the mails going, and the homework. But Dr. Warren, let me tell you something, you and Dr. Koch, he's not there right now, but there's a lot of excitement which was generated across the country. And all the IRSI members, huge amount of concentration. And this will go a long way in the history for us to find out and get to the bottom of solving this 2020 problem in this year. And it will help us in the long run to see how we can get you more data and how we can work on this as universal surgeons across the world to see that we conquer and we come across to see that we get the best results for our patient. That last 8%, we have to work very hard for the next few years. Thanks so much, everybody, for being there and sparing your valuable time. It's been a great time. Dr. Titial, thanks so much. Ramu, thanks. And Bhavikar, Dr. Gaurav Luthra, of course, always all backbone support. Thanks very much, everybody. And once again, Dr. Hill, thanks very much. Have a wonderful weekend.
It's my great pleasure.
Thanks, Warren. It was great catching up again.
Likewise. See you soon.
Bye for now.